Hi everyone, thank you for joining my live. I know there were a lot of technical glitches earlier. I'm Dr. Rakhee, consultant pediatrician. Let me try again to add both of my speakers today because it's a really good topic and I'm just gonna try my best to add both of them in. Hi Anisha. Okay. Yes. Hi Dr. Alex. Okay, wait.
Oh,
Only she can be in your live room. Okay.
wow.
Excellent. Yay. So my fingers crossed work.
There we go.
Hi Anisha. Hi Yashmina. Thank you for joining us. Hi Dr. Alex and hi Miss Vasha. Thank you so much for joining the live. Thank you so much for initiating this topic. It's a different sort of pandemic, but definitely a pandemic that we've been in much longer than the current COVID-19 pandemic. So thank you very much for joining. To everybody out there who are joining us and who will be listening in or maybe watching the replay earlier, I have with me Miss Vasha Kaur, the Bariatric Surgical Registrar in London. And I have also with me Dr. Alex Miras, who is a consultant endocrinologist with the Imperial College of London. Welcome, both of you, to my lab.
Hi, thanks, Rakhee.
Thanks for the invitation.
Would you like to introduce yourself? Tell us a little bit about yourself, how you got into what field you went into.
So I'm Vasha. I am a surgeon who's been very interested in metabolic health for a long time, both obesity and diabetes. Maybe not purely from a surgical perspective, but also from a medical research perspective. I grew up in Malaysia, which is how I know Rakhee. We grew up in the same part of the world for a long time, and I moved to Edinburgh for my training, and I've been living in London for the past decade.
Excellent. And Dr. Alex?
So I'm Alex Miras. I'm a consultant endocrinologist and lecturer at the college. I am the obesity physician here at Imperial, and I think we should get on with the presentations and with the discussion rather, and see how we can help contribute to this important topic.
Absolutely. I'll get right into our first question, which is, what is obesity?
So obesity is a chronic, progressive, very multifactorial disease that results in people holding on to more adipose tissue, and it can be a widespread sort of deposition of tissue, and it can affect almost every single organ system in the body, from cardiovascular to respiratory to reproductive, joints. I mean, you name it, there is obesity will have an effect on virtually every single system, and it has a progressive, and as a result of that, it results in lots of comorbid disease, plus in premature death, and for many patients, it can also have an effect in the quality of life and those sort of things. So it has a huge impact on our current population, and certainly it's not news to anyone that over the last, I don't know, 15, 20, 30 years that we've seen a very gradual increase in obesity prevalence throughout the world. And that's not only in Malaysia, but throughout the world. And that is a global pandemic, a global phenomenon that's been very evident. And one of the reasons for that is because although we recognize that obesity is a very complex disease, we don't have we haven't yet fully eluded the cause of obesity, and that's something the kind of research that Alex is doing would certainly help to contribute towards. But until we know more about the cause, we'll have difficulty determining how to manage this ideally.
Yeah. So why are we so worried about obesity? I mean, what can it do to our health? Why can't we just be obese people? You know, what happens? There's a question there. You know, what happens to our health? You know, why are we so worried about obesity? Can't we just be fat?
Yeah, I mean, there are people who promote the fat fit theory. Personally, I don't think it's something that is a very real phenomenon. I think it's something that progressively patients with obesity will develop ill health one way or another, even if they aren't at that particular period unwell. And so obesity is the reason why it's unhealthy is because our bodies, with increased fat deposition, you are at high risk of developing, as I said before, cardiovascular, respiratory, diabetes, and also the risk of cancers improve. And all of this will contribute to premature death and poorer health while patients are alive.
I see. So how do we know we are obese? Or, there are three categories. What we grew up don't know as doctors is I'm either normal, I'm underweight, I'm normal, I'm overweight, or I'm obese. I didn't even know there was a term morbidly obese until many, many years later on. Yeah. But how do we know which category we fall into?
So we use markers like the BMI, which is a body mass index. It's a very crude marker, but it's very reproducible. But it's also inexpensive. It's easy to use, and anyone anywhere can use it. And that is a measure where you take your weight divided by the square of your height, and you use that. So if it's anyone below 25, you'd say it's healthy. 25 to 30, overweight. Above 30, it's in the obese category, and that can then be further subdivided depending 30, 35, the different classes of obesity. But BMI in itself is not perfect. It doesn't tell you where the fat lies, and where the fat lies obviously has relevance, whether it's in the subcutaneous tissue or further on in the abdominal tissue. So there are other markers to decide about obesity, which is less good obesity. So things like abdominal girth. So we use waist circumference or the waist hip ratio, and abdominal girth is probably a better marker for I guess disease obesity or pathological obesity, where you're more likely to develop health problems. And I think the World Health Organization say that for women, it should be less than, your waist hip ratio should be less than 0.85, and for men less than 0.9, I think. And anything above that will suggest that you have increased abdominal girth and increased risk of cardiovascular disease. But there are a few other ways of measuring as well, but those are probably the most inexpensive and easy to reproduce measures for obesity.
I see. And why is obesity rising at this point? I mean, besides the lockdown prior to pandemic, we're all not sitting at home and binge eating, but we do see a trend of obesity rising even before COVID hit. Why do you think that's happening?
I don't know, Alex, do you want to take that, or do you want me to?
Yeah, so what has happened is our genes haven't changed in the last 50 years, but what has changed is the environment. And what the environment has done, it has unmasked our predisposition, or some people's rather predisposition to developing obesity. So what is it? Everyone says it's the environment, and we need to change the environment, and that is absolutely fine. So prevention, changing food availability, changing the cues, that's important. However, what we need to understand is that in the current environment, some of us are of normal weight, some of us are obese, and some of us are underweight. And that hasn't got anything to do with the environment, because we're all exposed to exactly the same one. So that leads to the very strong contributions of genes, our genetic makeup, which determine about 70% of our chance of developing obesity. So those of us that are normal weight, we are not smarter, and we are not more disciplined to the ones that are obese. We are just lucky.
To put it shortly, we're just lucky. Oh, that's interesting. So why are some people thin and some people not? Like, I mean, I've known Vasha since she was young, and I know you've been thin your whole life, so, like, why are some people just always thin, and why are some people not?
So just like any other human characteristic, we have people who are on either ends of the, like a normal distribution. And we know that what we know is that obesity can be determined by things like genetics or epigenetics, and even for genetics, it's very polygenetic. There's lots of different genes that can determine it. It's not as easy as saying there's one particular thing, and if you have this, you have obesity, and something else you don't. But also how our genes interact with the environment. And at the moment, the environment that we're in at the moment is almost one which promotes fat deposition. Everywhere we go, we see advertising, we see high palatability, high fat food, which is quite often lower priced than food which is more healthy. So we are living in an environment which is pushing us towards developing increased fat deposition. But also I think it's very important to, what Alex is maybe trying to allude to is that as a contemporary society, we often lay the blame for obesity at the feet of people who are obese. And I think that's perhaps very, very unfair, because the culpability and the stigma around obesity is always laid down to the fact that those people maybe overeat or do less activity than they should, when actually I think that's very untrue, because they are biologically designed, their bodies are biologically designed to retain calories or to seek calories. So they have hunger perception that's different from ours. They have increased muscle fatigability that's different from people who are leaner. And that hand that they've been dealt, that genetic hand that they've been dealt, is just their genes and how their genes interact with the environment that they're in. So two different people in the same environment, one person who's predisposed to obesity will more likely gain that weight and develop obesity than someone else who doesn't have that. And understanding that genetic makeup is very important, but also I'm hoping that it will start to shift the focus away from patients who are obese being culpable for their physique. The responsibility maybe will lie with them, but understanding that it's a lot more difficult for patients who are pre-designed that way to lose the weight than someone else who's not. And the kind of options that we have for dealing with this is varied, but we've got we don't have at the moment something which is not invasive and 100% effective to deal with obesity, which is why we have this pandemic that we're in at the moment. But I feel that's very important to understand that the blame for obesity, it's a biological problem. It's a problem which is rooted in biology. The core mechanism underlying obesity is rooted in biology. It's not, doesn't lie in choice. I've yet to meet a single patient who has ever said to me that they had chosen to be fat. I've never met someone like that. So I do think we need to, the main reason why I agreed to do this is hopefully to also, so the people who watch this will understand or appreciate that the culpability is not where we've, as a society, or often put it down at the patient's responsibility. The responsibility to maybe overcome the causes of it is obviously with the patient, but the cause of it is outside of their control.
So when you mentioned environment, were you talking about the temperature, the climate, or were you talking about food availability or marketing gimmicks? What exactly were you talking about when you talk about environment?
The diet that we have at the moment, the environmental cues for food, the kind of, I'm just wondering, is Alex still on with us, you think?
Yeah.
No, I hear you very well.
Oh, okay, because on my screen,
we just can't see you very well, but we can hear you. Yeah, that's fine. It's okay, carry on. So you're mentioning about the environment aspects. What are the environmental aspects?
We live in a land of plenty at the moment, don't we? Like there's, over the last 25, 30, well, since the war really, so the last 80 years or so, we've got improved health availability, improved food availability, per capita food and food consumption has increased dramatically in this time. So we went from a time when people were often rationing food, and in the early days people kept doing that even after the war, but in the last 50 years for certain, that's changed drastically, and we now live in a land where food is very easily available, and unfortunately cheap, less nutritious food is more easily available and often cheaper than the healthy options. And as a result, I think more often than not we would choose to buy food which is less good for us. I was hoping that we could have a bit of a chat about the mechanisms behind obesity, and I know Alex has a very good talk about that. I'm not sure.
I think Alex, you can hear him, because I wanted to go into appetite regulation. So I'm pretty sure that's down Alex's lane, isn't it? So Alex, if you're with us, do you want to tell me more a little bit about appetite regulation? How do we regulate that? Is it a disease of the brain, or is it something that I can control?
You can hear me okay?
Yeah,
we can hear you okay. Your video is out, but we can hear you. Yeah, but yes, fine, we can still hear you clearly.
it is very important to understand which organ is responsible for the development of obesity. For example, in diabetes, we know that the organ responsible for type 1 diabetes is the pancreas. The organ responsible for obesity is the brain, and just the brain. It's only one organ. The appetite centers of our brain are located in a small gland, which is called the hypothalamus. And this is the key. This is a very small area of the brain which regulates our body weight, it regulates our hunger, and it regulates our fullness. And this is where the genes that are associated with obesity can express themselves. So if there is a problem in our genetic makeup, the appetite regulation will be abnormal, and that will make the person overeat. Whether that person likes it or not, I'm afraid, because the signals that come from the areas of the brain that determine our intelligence and other cognitive functions cannot stop the signals that are coming from the hypothalamus. That therefore means that the person is constantly hungry and they are not full when they eat. So in order to summarize that, the way that I express it is that overeating does not cause obesity. Obesity causes overeating.
Oh, that's a total shift, mind shift, you know, like we always thought we're eating more, that's why you're getting fatter, but this is the total opposite. You're already obese and that's why you need to continuously eat. Is that what you're trying to say? Because you're obese, that's why you're eating more? It's like a different cycle?
Yeah, so the disease of obesity, even if before you are overweight, the disease of obesity has decided that you will become overweight. And that makes you overeat. And it is not overeating that causes the disease is already there.
I see. So what are the principles of treatment then? How do we treat this?
Okay.
I mean, mind over matter?
Okay. So just because we have described this as a disease, it doesn't mean that it is all doom and gloom, yeah? So there are ways that this can be dealt with, but what I'm trying to say is that there is no point telling people to eat less and exercise more, because that does not address the actual problem. So the problem is, as we said, in the hypothalamus and in the abnormal regulation of our appetite. So the principles of treatment is that whatever is going to work needs to be smart, because that system is smart in its own right. It's very smart. And that's why so many lifestyle modification approaches, so many medications, and even surgical procedures have not managed to deal with it. So the key principle of treatments, and Vasha will tell us about the available treatments, but the key principles of treatment are that they need to work on that part of the brain. And they need to lower hunger and increase fullness. If the treatment that we're giving the patient makes them hungry in the first few weeks or so, it is doomed to fail.
Oh, okay. Wow, that's an interesting. We never thought of it that way. You know, we are always told, it's always indoctrinated into us that, you know, if you don't exercise, if you don't stop eating so much, control your diet, intermittent fasting, stop eating at a certain point, go keto, go vegan, go whatever, all these fad diets. We are always told that somehow or other this is going to work. But, you know, looking at the facts that you've just put across, this is obviously not the right direction we should be focusing at.
Well,
so Vasha, you wanna?
It's
what I'll say, and I'll say one couple of things, and Vasha will follow up on what I'm going to say, and that is that usually severe caloric restriction does not work. It doesn't work in 80 to 90% of my patients. So this simple approach of eating less calories, it is unlikely to work, because it just makes people hungry. May not make them people hungry early on, but it will eventually make people hungry. So that's what I'm saying, that any approach that we use should be smart. And intermittent fasting, changing the macronutrients we choose, can work in people. And that's what Vasha is going to tell us now.
Okay, go ahead, Vasha. Let us know what's going to work.
I think to follow that, I think one of the reasons, so I think to start off, well, there's a theory that we use at the moment, which is that most humans under stable environmental stimuli will maintain a steady weight throughout their entire adulthood. They'll maintain the same weight, and the very, very minor shifts in weight if there's constant environmental stimuli. And the reason for that is because we have almost a pre-programmed weight that our body, just like every other homeostatic mechanism in the body where there's a feedback, any other endocrine feedback system, the same applies for the fat system. And our body wants to maintain a level of fat tissue and muscle tissue that's stable for us. So when patients do what we often call yo-yo diets, and you take extreme measures to lose weight, you lose all this weight, your body is still, and when you lose weight, when you go on a yo-yo diet, you're employing your cortical function, your higher thinking function. You're trying to overpower your instinctive neurological systems that are telling you whether you're hungry or not. So you are using your own motivation to go past that. And you do your yo-yo diet, you lose a lot of weight. Very, very few people will maintain the diet for a protracted time. So it tends to be a short-term thing. You then go back to your normal eating. Your body will then try to compensate. When you lose weight, you lose fat, you lose muscle. The first thing that your body recovers is fat. And only then will you go back to gaining your muscle. It takes a lot longer for your fat-free mass to be replaced than your fat mass. In this whole time, while gaining your muscle mass back, you will continue gaining your fat mass. But the fat mass often overshoots. So it goes beyond the amount of fat mass that you may have had before you started the diet. So even you may actually end up, even if you're a normal weight individual who often does yo-yo dieting, you may find that in the longer term, you will end up being heavier than you were before you started this. So this effect of yo-yo dieting is actually far worse for you, far worse for your weight. I think we've lost Alex. Far worse for your
he'll join back in. Yeah,
and your fat mass. So that's one reason why we never promote things like yo-yo dieting. Whatever lifestyle measures we take, it has to be sustained. A very small percentage of people will end up losing weight purely with diet control. I'm not saying no one does, but it's a very small percentage of people that end up losing weight. And I mean something like more than 5% of weight loss is a very small percentage. And even smaller percentage will maintain this weight loss for a protracted period of time. Most people that effect will be lost, and they will regain the weight back. So that's why, but things like intermittent fasting is helpful if it's sustained. It is helpful. People do lose weight intermittent fasting, whether that's the 16-8 or the 5-2 or things like that. It does help, because in that period of fasting, your body does tend to change your metabolic response, and you may lose weight, but you have to keep it sustained. The sustaining or the weight maintenance or the diet maintenance is probably the key thing here. So lifestyle modification. Outside of diet, the other things that are very important are things like sleep regulation, good sleep hygiene. Good sleep hygiene. Sleep is a modulator of neuroendocrine function, and if you people with poor sleep also display things like hyperphagia. So they're more hungry. They may have lower leptin levels. They have different. They might seek different types of food. Just like high stress levels, you have. When you have high stress levels, your basal energy expenditure actually decreases. So your body tries to go into almost like a protective mechanism. So they notice the increase in cortisol levels will result in increased fat deposition, increased sugar intake. You seek certain kinds of food, and all of this will result in. So although we say when the reason why we don't say diet is because it's more than just the food. It's the activity, the stress, the sleep. It's it's lifestyle modification. But again, this is if it worked, we wouldn't have obesity. As Alex said before, this is a very sophisticated system, and to overwhelm a sophisticated system, you need a sophisticated solution. And eat less, do more will work in some patients, but it's probably too simplistic a mechanism to use to overwhelm the system. And the set point theory that I talked about earlier, where you have a set point of weight, is not something that you cannot overwhelm. You can certainly overwhelm it. We know that from the times of war and things like that, when patients had very little food available, people did lose weight. Everyone was, a lot of people were extremely skinny, and they probably went below their set point weight. And similarly, even if my set point weight is a particular thing, I know that the pandemic, I've gained a lot of weight because I was probably eating more than I normally would. And so you can overwhelm the system and you can move up and down. But if you take on the lifestyle modifications and you take 100 people who do these things, you'll probably find in the longer term, 24, 48 months, probably have less than 5% of people who will manage to keep their weight off. And that's why it's not the best option available. There are pharmacological options, so maybe Alex will want to go into. And then
I'll quickly talk about pharmacotherapy, because I've seen some questions that have come up with that. So what pharmacotherapy does, all of pharmacotherapy, it addresses hunger and fullness in the brain. And we now are lucky that our options for pharmacotherapy are really improving very, very fast. We had appetite suppressants in the past that had lots of side effects, and they were withdrawn. But the appetite suppressants that we have now are very, very safe. The one that is more widely known around the world is called Saxenda, or liraglutide 3 milligrams. I'm assuming it is available in Malaysia because it's available in most countries. The other one, which is becoming more and more popular, is semaglutide, which is a sister drug of Saxenda, but the difference is that, number one, it is given once a week as an injection instead of once a day. Now we have got semaglutide available for the treatment of diabetes at the dose of 1 milligram, and the 1 milligram of semaglutide has got similar efficacy to the 3 milligrams of liraglutide. But you'll be aware that in the last 5 weeks, the FDA, the Federal Drugs Administration in the US, has approved the use of 2.4 milligrams of semaglutide, which causes a mean weight loss, an average weight loss of 16%, which is double that of Saxenda. So very fast progress in the field. In the semaglutide studies, approximately 30% of people lost more than 20% of their body weight. So we're now getting into the ranges that bariatric surgery can achieve in terms of weight loss. And that is with 1 injection per week. The principle here is that with pharmacotherapy, like lifestyle modification, you try it for approximately 3 to 4 months. If the patient has not lost weight with these drugs in 4 months, you're wasting their money and their time. You need to switch to something else. An alternative final option here in the UK is the combination of naltrexone and bupropion. Here in the UK, that's called Mysimba. Now that is a tablet, which is taken 4 tablets a day in total. And again, it works in a similar way to the injections, but only slightly different. And it causes a weight loss, which is approximately 6%, which is not bad. But the newer medications for obesity, as I'm saying, they are in the category, in the range of what bariatric surgery can achieve, or they're getting very close to that.
So basically, it's lifestyle modification, then it's pharmacotherapy, and you've got various pharmacotherapy now that are much safer than before. We have a question about Ozempic. I'm not sure if you've heard of Ozempic as an off-label use for weight loss. What is your thoughts on that?
Yeah, Ozempic is semaglutide, but it is semaglutide at the dose of 1 milligram. Now that is available for people with diabetes, but I use it as your as your participant is alluding to, out of license. Okay, so I'm using it in people who do not have diabetes for weight loss. The difference is that in the public healthcare system, the cost of Ozempic is covered. So the patient doesn't have to pay if they have diabetes. If they have obesity without diabetes, unfortunately they have to pay. But the good news is that Ozempic is a lot cheaper than Saxenda.
I see. And if this does not work, like you said, in 3 or 4 months, and there's no difference, that's when you move on to bariatric surgery, is it? Or you move on
so you can move to another drug, or you can certainly think about surgery, and Vasha will tell us about surgery now.
Yeah.
Go ahead, Vasha.
So I think there are certainly options of bariatric surgery. I think people come to it after a lot of consideration, because it's very it's irreversible. We said there is reversibility, but really once you've gone down that track, it's not something that you want to go back on. So
yeah,
maybe this is not the right platform for discussing the different surgical operations, but there are certainly surgical operations that we can use for patients with obesity. And the main hub of it is that the focus is on the first part of the small bowel, the duodenum, and either increasing passage of food through the duodenum or bypassing it completely so there's no absorption to the duodenum. There are different options like the sleeve gastrectomy or gastric bypass operations. The focus is the same. The idea is that you have a new set point to start your weight regulation on, and that the gut-brain axis, so the gut signals to the brain and the brain to the gut, is reset. So you're not having those hunger pangs. You're not having those. You're not seeking the same sort of food, and it's not purely. It used to be thought that it was a restrictive or a malabsorptive effect from having the operations, and that's certainly no longer the feeling that we use at the moment. We think it's more that a couple of different things. So it can be the mechanisms behind the gut-brain axis has changed, or that it changes the bile acid absorption, it changes the gut microbiota. We know that patients who are obese have got gut microbiome, which is more, so it kind of makes it a bit more aligned to weight loss. And so the different mechanisms of how it works. But they do seem to be the most effective treatment that we have at the moment. So surgical management for weight loss is certainly by far the best treatment we have at present. I think pharmacotherapy is fast approaching. Things have changed very quickly in the past decade, and certainly that's a space to watch, I think.
And is it a combination? Like, do you usually, for Dr. Alex, do you usually work hand in hand with Vasha with regards to, like, she does the surgery, you give them the medication? Is that also an option, or it's either one?
So we do not consider it as discrete blocks. It's part of a continuum. We treat obesity like cancer. In cancer, there is no arguing between the surgeon and the oncologist. They use for the patient what's best for the patient. That can be chemotherapy, it can be surgery, it can be surgery with chemotherapy. Okay, there is no competition between medicine and surgery. So most people who have surgery respond very well. They lose 25 to 30% of their body weight, which is great. They also have significant improvements in the complications of obesity. But for some, the weight loss is not enough initially, or they regain weight after these operations, and that's nothing. And when people regain weight after surgery, it's not the surgeon's fault, it's not the patient's fault, it's not the operation's fault. Okay, it's just that the signals from the gut to the brain, the way that the gut talks to the brain, has changed, and there is not much that we can do other than add pharmacotherapy to the patient. So we have found, and we have published on this, that pharmacotherapy medications can work after surgery. And therefore, together, the effect is optimal. And that's about it, really, in terms of treatments. That's what is available at the moment. Things will change. But yeah, combination treatments are increasingly being used. And what we're trying to do...
Sorry. How you were saying something?
We're trying to do two things. First of all, optimize the medical therapies that are available to make them more effective, have fewer side effects. Reducing cost is really important because for an operation, the cost is high initially, but then the operations are very cost effective. We call them a free Ozempic for life, if you think about it, because this is how they work. Whereas medications can be costly in the long term, and they are not yet as cost effective as surgery. But we do combine the two, and we're also, finally, that's what I want to say, we are optimizing not only surgery, not only medications, but we're currently doing trials to optimize surgery itself, because we don't think we have still reached the best operations that we can use.
And if a patient is on pharmacotherapy, on certain medications, how long do they have to be on it? Like at some point, do you feel like, okay, we're going to tail it off and you're fine, you can just go on with just lifestyle modification? How long is usually that they're on drug medication?
I get asked this question a lot, and I think it's a very interesting question. Sometimes I prescribe medications to colleagues and who are doctors, and they also ask me the same question. And what I reply to them is, when people are taking things like thyroxine, for hypothyroidism, or they're taking statins for cholesterol. Okay, so how often do you start on a statin and then you ask the doctor, when am I going to stop taking this statin? That question never comes up, because automatically it's going to be for life. You don't ask, when am I going to stop it? Because you know that if your cholesterol goes down with the statin, you need to carry on taking it. Because if you stop taking the statin, guess what will happen to your cholesterol? It'll go up to exactly what it was before you started. The same applies with weight loss medications. I know it is an uncomfortable conversation with patients. They're saying, what, forever? Why should I be taking this forever? Because if it works, you will lose the weight, and then when you stop it, you're going to put the weight back on. So it is a long-term treatment.
I see. In our country, in our setting, we have a lot of local remedies, which include certain teas that make you go to the toilet more often. We have all these herbal stuff that make you have a tummy upset. And, so a lot of the local Malaysians here, we believe in that rather than seeing a doctor. So everybody will just go off to the pharmacy, pick up some pill that says, if you drink this tea one sachet once a day for a week, you lose 10% of your body weight. So that's like the fast action. So what are your thoughts on these sort of fast remedies rather than, a wholesome, do they work, or is it body loss?
I never poo-poo remedies, okay? So some of the remedies that you're using may be very, very effective and very, very safe. The only problem is that we don't have got any evidence for that. That's the difference. Vasha, you understand that field a bit more, I suppose.
Yeah, I think you're right. In Malaysia, there is certainly a feel for, don't talk to the doctor about it, but I'll talk to my neighbor about it instead, right? And I think the other thing I want to just quickly mention is that in Southeast Asia, you have a lot of people who have slightly slimmer builds, who may actually hold on to more visceral fat. So you have the thin fat. I think that's certainly maybe a dangerous position to be in, because it's very easy to ignore the risks that you have from that fat deposition. And so I think people should certainly keep an eye on their abdominal girth. That's certainly a good sign, but keeping an eye on their metabolic health. And I know this was mainly meant to be about obesity, but things like your blood sugar, your cholesterol levels, your heart, just to make sure you're not ignoring the other signs just because your weight is in what you think is a normal weight. Because weight itself is not a good marker for metabolic health. But yeah, in terms of
there was a question.
I cannot condone.
Yeah, there was none of us condone it, but we all try it at some point for fast weight loss. There's a wedding coming up next week. Let me just try this tea for 3 days and see if it works. I think it's just water loss, but yeah, I think it's better if it's a wholesome approach. There was a question earlier: how important is mindset towards one decision to curb obesity. Do you feel that mindset is
Okay.
also very important in what both of y'all are advocating?
It depends on what the definition of mindset is. If we think this is a matter of discipline, i.e., you need to be disciplined to lose weight, that's not valid anymore. That is a myth. Okay, so what Vasha was saying earlier on is that obesity is not the patient's fault, but it is the patient's responsibility to deal with. Okay, so when the person assumes and takes over this responsibility, okay, that's all we need. Nothing more than that. As I say, I have got many colleagues of mine that are overweight, very smart, successful, disciplined people. They have managed to achieve everything in life, but they have not managed to lower their body weight. That tells you a lot about the myth that discipline is needed to lose weight. What's needed to lose weight is the responsibility to want to do it, yeah, to take control as much as you can of the disease, and to try things that do not make someone hungry.
Yeah,
absolutely. So do you both have any final advice or final tips to everybody out there who are struggling and who are, I won't name names, but maybe me, struggling to lose weight and tried everything possible, but but we do know a lot of people who have never achieved that so-called, what you said, there's a weight set point. Like maybe for my build, I'm supposed to be at 50 kilos. I'm just throwing a number. And I've never been able to achieve that. So sometimes it makes you depressed, and depressed makes you binge eat, and then that whole cycle starts again. So do you have any tips, any advice for people out there who feel like they're going through pandemic fatigue, they're going through obesity pandemic, they're going through so much? So what is your advice to all of us out there so that we manage our weight in a more sustainable way?
Vasha?
I think that firstly, when I mentioned the set point earlier, I meant that not like your ideal weight on your BMI spectrum, but what your body perceives as your set point. So that may well be different from what your ideal BMI is. And and that I wanted just to clarify that's what I meant by that. But in terms of how to give yourself the best chance of losing weight, and I'm suspecting you mean without having to go down the surgical sort of path, things like making sure you get good sleep. It's easy to say decrease your stress levels, but trying to make sure that you have a stress or you mitigate the highest stress levels if you can, and a healthy diet and physical activity are the only kind of lifestyle measures that we do have at present. It's certainly not going to cover everything that everyone needs, but it's probably the best starting point. And sustainability. So whatever measure you put in place, particularly in terms of diet, is something that you need to know that you can keep it going, and not for 2 weeks or 2 months or something we're talking about years. Long-term weight management, long-term diet modification. So then I think if you can find a way, so like things like 5-2 or 16-8 allows for some naughty habits, while the fasting happens. And I think that's something that most people can accommodate. Because if you're going to be stringent with yourself, you can do that for 2 weeks, 3 weeks, 4 weeks, but it's difficult to maintain that level forever. And I said before, even you can't talk someone thin. Even if I engage all your cortical functions and you're really motivated to want to lose weight, it's not going to stop your brain sending a signal to your stomach to say that you're hungry. You're not going to stop your ghrelin being released. You're still going to have those kind of metabolic and physiological responses to hunger. And how you overcome that, it's a whole different matter. But yeah, that's it for now. Sleep well, low stress, eat well.
I hope most of us do know what extreme means, like soup diets and carpets diets and all that kind of stuff. It is unphysiological. It is impossible to live on a soup diet for the rest of someone's life. And not only that, but if you do use extreme means of losing weight, you are not only going to fail in the short term, but you will also sabotage your chances of being successful in the longer term. Okay, so you're really doing damage to yourself, and therefore I highly recommend you stay away from these extreme measures.
Excellent. So in summary, what we've discussed today for everybody who maybe have just joined us is we talked about obesity. We talked about how we diagnose obesity, the effects of obesity on our health. How do we measure BMI and all the many other measures of obesity? And it's not just your weight. There are many aspects to it as well. We also discussed about how some people are genetically just thin, and the fact that it's not overeating that's causing obesity, it's obesity that's causing you to overeat. So to everybody out there, it's actually something that is different compared to what we're always thinking about. We also spoke a little bit about appetite regulation. We spoke a little bit about weight set point, which is not what you're setting it at, is what the body has already set it at, right, Vasha? So your ideal body weight is not your weight set point. It's already something that your brain has determined that, okay, you're going to be at this particular weight. So that's one of the reasons why some who are obese have a lot of difficulty in losing weight. So it's not that they're lazy, like what Dr. Alex says, we know a lot of obese people who are super efficient, who are disciplined in many ways, but they just struggle with weight. So it's not about a blame game. We should not be fat shaming anybody. It's something that is genetic, and it's also environmental. And like Vasha mentioned earlier, in the past, I think 100 years, a lot has changed. I mean, looking at what my parents and my grandparents used to eat versus what my kids are eating now, I know there's a shift towards more unhealthy food. So I think there are lots of ways out there to lose weight, but generally going at a slower way, in a more sustainable way, getting pharmacological management in, and then lastly would be your bariatric surgery or surgery for weight loss. So either way, also, if you struggle, please see a physician. A disclaimer here, whatever Dr. Alex and Ms. Vasha have mentioned are not personal medical advice. This is general medical advice for information of everybody in general. So it's not particularly to anybody in any way. This is not personal. So I'd like to thank both of you very much. I'm so sorry to everybody who have joined in earlier in the first couple of times when we had a bit of technical glitches. This was absolutely wonderful, insightful, and I'm so glad that we managed to keep you on board, Dr. Alex. In between here, we lost you for a bit. But thank you so much, guys, for all the information that you've given us. Any parting words before we log off?
No, thank you very much for the invitation, and enjoy the rest of your, whatever is left of your day in Malaysia.
Thank you so much, Alex. Yeah. All right, Vasha.
Thanks, Rakhee. Take care. Bye-bye.
All right, take care then, everybody. Bye-bye.
Bye.
Bye.